Everyone to this month's Bariatric Happy Hour. We are joining you from across the globe. I am in India right now, and our guests are from Abu Dhabi, and the others are from United States. We are so excited to have you here for another engaging session where we connect, learn, and share insights on all things obesity and metabolic surgery related. I'm your host, Dr. Faiz Shariff, and I'm thrilled to be co-hosting the session alongside my esteemed colleague, Dr. Juyeon Park. So grab your favorite beverage and settle in, and let's dive into another insightful conversation. But before we do that, I have just a few announcements. Our next fellow project is on March 7th. It's going to be on blame games, so the stigma associated with obesity. So join us for that. And don't forget to apply for the mentorship program. That's an awesome program from FASMBS. And finally, your annual meeting is coming in, and the early bird registration will be available shortly. So take advantage of that. Now, without further delay, we are honored to welcome Dr. Michelle Gagner as a guest speaker for this month's Bariatric Happy Hour. A world-renowned surgeon, Dr. Gagner has been a pioneer in laparoscopic and bariatric surgery, credited with groundbreaking innovations such as laparoscopic sleeve gastrectomy, laparoscopic duodenal switch. A native of Montreal, Canada, Dr. Gagner has held esteemed positions at institutions such as McGill University, the Cleveland Clinic, Mount Sinai School of Medicine in New York, and Cornell University. His leadership in minimally invasive and robotic assisted surgery has transformed the field, with achievements including the first transatlantic robotic assisted surgery. This was published in Nature. And that's not it, there's much more. Dr. Gagner's contribution to surgery have been recognized with numerous awards, including the SAGES Pioneer in Surgical Endoscopy Award, the Surgical Innovation Award from FASMBS, and Excel Award from Society of Laparoscopic Endoscopic Surgery Surgeons. He has received multiple medals from the cities of Marseille, Bordeaux, Nice, and was honored by the French National Assembly. His lifetime achievements have earned him a place in Marquis' Who's Who and the Albert Nelson Marquis Lifetime Achievement Award. Currently, he serves as a professor of surgery at the University of Montreal and operates his own specialized Westmount Square Surgical Center with over 400 publications and 10 books. He remains at the forefront of innovation in metabolic and bariatric surgery. During this session, Dr. Gagner will share insights into his work with magnetic anastomosis in bariatric surgery, a cutting-edge technique poised to enhance surgical outcomes. And with that, Dr. Juyeon Park is going to introduce our next guest speaker, who is a rising star. Dr. Park, take it away.
Yeah, so for our fellow presenter today, we have Dr. Kevin Lynch. He graduated from Elon University for his Bachelor of Science back in 2013. He then went to West Virginia University, Morgantown, West Virginia, for his medical degree, and then did his general surgery training over at University of Virginia. And now he is over at Duke University in Durham, North Carolina, doing his MIS Bariatric Surgery Fellowship, where Dr. Shayna Eckhouse is. Hello. So, Dr. Lynch, take it away, share your slides.
All righty, let me see. Okay, can you guys see that okay? I'm gonna try to get into there we go. Is that showing up okay? Okay, awesome. Well, thank you, Dr. Park, for that introduction, and thank you to everyone at FASMBS for letting me be here as part of the discussion, and thank you to Dr. Gagner for being here to join us. I'm privileged to present your article. This is an article on the creation of side-to-side magnetic duodenal ileostomy with or without prior or concurrent sleeve gastrectomy, and this article was published in Sword last year. This is a quick overview. So the article begins with a brief introduction. We talk about the risk of anastomotic leak after SADI or DS. Though rare, these can obviously be catastrophic for patients, and as is pointed out by the article, can raise their rate of mortality by up to 30 to 35%. These, of course, are also associated with ICU admission and organ dysfunction, and of course, reoperation. The authors point out that these may be linked to foreign materials, and that foreign materials such as staples or sutures and anastomoses may result in chronic inflammation that can also be associated with chronic infection or in the long-term development of anastomotic strictures. Their group has therefore developed a foreign material-free anastomotic magnetic technique, which can be used to create materials without leaving any residual foreign bodies behind. The authors report on a prospective open label study of side-to-side magnetic duodenal ileostomy, which they refer to as a MAGDI, and I'll use that verbiage kind of throughout this review of their article. The study consisted of two stages. The first was a design as well as a safety and preliminary efficacy trial at one site. And the second stage was the introduction of this technology to a total of 4 sites, with 3 sites performing concurrent MAGDI with sleeve gastrectomy, and the 4th site offering MAGDI as a revisional option for patients who had previously undergone sleeve gastrectomy. The primary endpoints for the study were related to technical feasibility as well as safety. Additionally, the authors ensured that duodenal ileostomy was patent at 3 months and 12 months through either radiographic or endoscopic confirmation. They also studied the successful passage of the magnets and confirmed this with imaging. Their secondary endpoints were related to the proportion of patients with weight loss, which they deemed as successful if it was greater than 5% of total weight loss, as well as the portion of patients with improvement in their overall hemoglobin A1C and glycemic control amongst those patients who were diabetic prior to surgery. This is kind of a brief schematic of the magnet. You can see it's not quite to scale. It's actually quite small. Its dimensions measure 0.75 by 0.25 by 1.25 inches, so quite small overall. In terms of the placement technique, I'm going to review that briefly over the next couple of slides. So first of all, and I thought this was a pretty interesting and cool technique, the distal magnet is transported from the duodenum to the proximal jejunum endoscopically, and this is left in place with this kind of attachment here to the endoscope. Next, there's a laparoscopic positioning device which moves the distal magnet, I'm skipping ahead. Next, titanium clips are placed to mark the ileum approximately 250 centimeters proximal to the ileocecal valve. And now a laparoscopic magnetic positioning device is used to move the distal magnet from the proximal jejunum into the marked ileum. Following this, a proximal magnet is introduced endoscopically into the duodenum, and the ileal magnet, the distal magnet, is now brought up in an anticolic fashion using titanium laparoscopic graspers, and these are opposed to the more proximal magnet on the anterior border of the duodenum. And then, of course, finally, Peterson's space is closed using a permanent suture laparoscopically. So this figure, which was taken from the author's study, shows kind of the overall schema. So you have a completed sleeve gastrectomy, you have a proximal and distal magnet, which are going to create this magnetic duodenal ileostomy, and then you have closure of the mesenteric space here at Peterson's defect. So in total, the article reports on 43 patients who underwent a magnetic duodenal ileostomy, or MAGDI. 19 of these had undergone prior sleeve gastrectomy and were undergoing a revisional operation. The remainder underwent concurrent MAGDI with a sleeve gastrectomy. In all, these magnets were found to be placed successfully and to result in patent anastomoses at 3 and 12 months endoscopically or radiographically. As will be shown on subsequent slides, the MAGDI after sleeve gastrectomy group did have a few differences in terms of their baseline weight, diabetes, mellitus, and operative length, as well as hospital stay. So this is kind of table 1 taken from the figure. So as you can see, the DI group after sleeve gastrectomy relative to the concurrent group tended to have lower weights overall, having undergone a prior sleeve gastrectomy. They also were less likely to have diabetes at baseline relative to their counterparts who underwent concurrent sleeve gastrectomy with DI. Unsurprisingly, the operative time in the group that did not have to undergo concurrent sleeve gastrectomy was lower. These patients who had undergone prior sleeve gastrectomy had a shorter hospital stay and also somewhat shorter time for expulsion of magnets, which I thought was interesting. In terms of secondary endpoints, the first one that we looked at, or that the authors looked at, of course, was weight loss. At 3 months, both groups saw statistically significant reductions in absolute weight as well as the BMI, as is shown here. The magnitude of this change, though, was much higher in patients who were undergoing concurrent magnetic DI with sleeve gastrectomy relative to patients who were undergoing magnetic DI after a prior sleeve gastrectomy. And you can see that here. My screen is blocked out a little bit. The p-values were significant all the way across, but the overall reduction of the BMI was far higher at 3 months in the patients who were undergoing concurrent mag DI with sleeve, being 23 relative to 5.1 in terms of their kilograms of mean weight change. At 6 months of follow-up, this overall trend continued, and we saw continuing statistically significant reductions in overall weight, with, again, the magnetic DI with sleeve gastrectomy having slightly higher overall weight loss as relative to the magnet DI after sleeve gastrectomy, though both groups did experience statistically significant weight loss. And then finally, out to 12 months of follow-up, this trend was observed to continue. The authors do note that there was a reduction, or I guess not enough patients to follow with one full year of follow-up after surgery, and thus they did have to do some statistical extrapolation, just as a caveat to that finding. These results can all be followed graphically, and I think these pictures taken from the article do a really nice job of demonstrating what I've previously just gone over. So you can see at baseline, the patients who underwent magnetic DI with sleeve gastrectomy had higher weights, but over the course of the study period, they of course lost more weights relative to the blue group, which was the patients who were undergoing revisional magnetic DI after prior sleeve gastrectomy. And of course, their BMIs followed the same trend. With respect to total weight loss and excess weight loss, as I mentioned, patients who are undergoing magnetic DI after sleeve gastrectomy noted a statistically significant total weight loss as well as excess weight loss. And this was also seen in patients who underwent mag DI with sleeve gastrectomy. Between the two, the magnitude, of course, was higher in patients undergoing concurrent magnetic DI with sleeve gastrectomy. With respect to diabetes, there was a total of 9 patients who underwent MAG-DI with sleeve gastrectomy at the time of the study. 7 of those were being treated with medications at the time of the study. The authors reported that all had a reduction in their diabetic medications at 6 months, and that 6 out of the 7 have been able to stop their diabetes medications entirely. Even of the 1 patient who remained on diabetes medication, though, there was a statistically significant drop in hemoglobin A1C. And you can see that that was from 6.2 to 5.1. With respect to adverse events, there were a total of 64 adverse events related to or reported in the study. None of these were deemed to be device related. Most of the reported events were grade 1 or 2. The 15 that were grade 3 were all related to the sleeve gastrectomy, from what I can gather, or the mesenteric closure. So there were 7 serosal tears, which were repaired intraoperatively, 8 cases of nausea and vomiting, as well as 1 case of obstruction related to mesenteric closure, but none related to the device itself. There were no noted anastomotic bleeds, obstructions, or anastomotic leaks. So in conclusion, the authors, I think, appropriately conclude that MAG-DI placement was technically feasible and safe across multiple centers. And they found that these anastomoses were patent across 6 months, not associated with leaks or stenosis requiring repeat intervention. Weight loss was significant across both groups, the patients undergoing concurrent sleeve as well as the patients who had had a prior sleeve. And interestingly, I think there was a statistically significant drop in weight in patients who had prior sleeves who are now undergoing revision. Although, of course, when compared to total weight loss, the people who are undergoing concurrent sleeve gastrectomy with a MAG-DI saw a greater total weight loss overall. And that's the conclusion of my review.
That was a very, very comprehensive review, Dr. Lynch. Thank you for that review. Dr. Garnier, would you like to add some more information to this and show us some
Yeah,
videos on this?
yeah, thank you very much. I think it was very well presented. He did a good job. Thank you. Let me try to share my screen. Am I allowed? Okay.
Please share your screen.
So the version that was on this paper was the first version. And the first version was delivered by a short pediatric colonoscope to the ligaments of trites, the lower magnet. And this was a 3 centimeter or so long magnet. And this magnet was totally encased in titanium. You have to know the material inside is neodymium. It's called N42. 42 for megahouse, kind of the total force of the magnet. And these magnets are neodymium, iron, boron complex. So they're toxic and they have to be encased in titanium, and they're temporary implants. They stay there for several weeks and then they pass after necrosis. So we decided to make the magnet swallowable so we could avoid the endoscopy. So this is now the version 2.0, which is much thinner. It has been flattened, same strength. And instead of a little groove of titanium where the healing takes place, the healing takes place around the necrosis. We have put an absorbable material that is made of polyglycolic acid, and it dissolves in 2 weeks. The prior version that you saw stayed, up to 45 days in place, and I thought that was too long. And we thought that the titanium was pinching the tissue too long. So by absorbable, when they dissolve at 2 weeks, the necrosis alone is exposed, and then the passage of the magnet is much faster. We put this beside the Allurion balloon. I know it may not be used in the US, but it's pretty used worldwide. And this is a swallowable balloon. This is what the patient have to swallow. And it's about the size also of the pill cam, the camera pill that patients swallow. So to show how really thin it is and easy to swallow for the patient swallows this, and then we can avoid the endoscope going to ligaments or trites. So we've been doing this in patients with, for example, type 2 diabetes without gastrectomy, just a magnetic connection for the resolution of type 2 diabetes. So I'm going to share with you this video of this swallowable version, which is now approved by the FDA, the 4 centimeter version. So the patient comes in the morning, and we give the 4 centimeter magnet to swallow, and they swallow this with a sip of water. And we also have a 5 centimeter version, but it's not FDA approved yet, but it will come anytime soon for even larger anastomosis of the small bowel. Now, this is done for type 2 diabetes. 2 hours later, the patient is brought to the radiology suite, and you can see the magnet, the swallowed magnet is now in the left lower quadrant, which indicates it's in the jejunum. We then bring the patient to the operating room. This liver retractor is made of titanium. You have to remember that all our laparoscopic instruments, even robotic arms, are all magnetic. They're made of stainless steel and they stick to magnets. So if you want to manipulate a magnet in the bowel, for example, or so close to a magnet, you have to have instruments that are non-magnetic. So we have to change all our instruments with titanium or tungsten or other type of metal that are non-magnetic. So you divide the greater omentum. There are 4 trocars at the level of the umbilicus. They're disposable trocar because they cannot be metal trocars. They stick to the magnets. And at 250 centimeter from the ileocecal valve, we put titanium clips. We like this because it's a good radiological marker that tells us if the magnetic pair is moving in relationship to the site where the anastomosis is supposed to be. So, this is an umbilical tape. There's many way to measure this, and we start at the ligaments of Treitz, and now we're looking for the magnet. Now, these are what we call laparoscopic positioner device. They have different force. You can choose from 12 Newton to 27 Newton. Here, I started ligaments of Treitz, and I caught the magnet in a loop adjacent to it, but that doesn't mean it's in that first meter of small bowel. So I'm going to continue to run that bowel until I reach where the magnet is. Now imagine this is 2 hours after swallowing, so you can see that the magnet has traveled the esophagus, the stomach, the duodenum, and all this proximal small bowel. I forgot to tell you that we give mineral oil after swallowing the magnet, so it lubricates the intestine. This is an oil that is non-absorbed, and it's typically used for the treatment of constipation in kids. So after we've reached the magnet in the mid-jejunum, we're going to have to move this to where our clips are on the ileum. And we call this surfing. We surf the magnet that is in the lumen of the intestine to the point where the clips are located. Here I went a bit beyond, and I'm going to backtrack to where my clips are. So this is probably 21 Newton. Now, the endoscope is introduced while we were doing this, and it brought another magnet in the duodenum. And here I connect them. They just self-align. They're made identical, so it doesn't matter if it's left, right, up, and down. They will totally connect perfectly. But you want this to be away from the pylorus, not through the pylorus. And so the endoscopy below shows the magnet in the bottom of the duodenum, and you confirm that you're not touching the pylorus. Here I can microsurf this away from the pyloric vein, a distance of 1 centimeter to 2 centimeter distal to the pylorus. So we're truly a duodeno-ileal anastomosis. So I can really, sometimes it's too far, and we have to bring them closer to the pylorus. Some patients who've had prior cholecystectomy, the duodenum can be stuck, and you have to, before you do your procedure, make sure the duodenum is free from any adhesions, because you don't want to do this in the middle of the docking. Now we're closing mesenteric defect. I believe that the Peterson's defect, which is the on one side the mesentery of the mesocolon and the mesentery of the ileum, they're close together. You should see a U where they unite. And after that, we're going to make sure that the surfing bowel, this is the biliopancreatic limb. So we're going from the anastomosis back to the Treitz, inspecting all the bowel loops. And this is what you saw in the study. We had small serosal tear, and the tear are not coming from the surfing instruments. They're coming from these bowel forceps. So if you're not careful and you have an angle, you can cause little serosal cracks, and because it was a study, we were erring on the side of safety and put extra sutures, even though many people said, "Oh, it's not necessary," but we didn't want to have problems. And the going back to the Treitz is an important step to verify that there's no twist. This is an X-ray the next morning, so it's less than 24 hours, and we want to make sure that the pair is docked. We've never seen a pair undocked, but it's theoretical. For example, a thick male patients with a thick omentum, thick mesentery, when they're walking around, could have the pair undocked. There's no sutures holding all this. It's only the force of the magnets. And then before discharge, I think it's important to document that the pair. And now you can see if you rotate the patient, you can see a distance between the two magnets. The magnets are still not touching. The water gets expelled over time, and usually they will touch by the third or the fourth day. And that's the video. Just to show you the magnets that we have used for diabetes. This was 15 patients that were done in Georgia, the country, and class 1 obesity, only type 2 diabetes, only the magnetic anastomosis, no gastrectomy. You can see the body mass index was 33. 53% were female patients, all had diabetes, and we had 100% placement of these magnets and creation of the patent anastomosis, and the median expulsion time was 24 days. That is when it comes out by defecation. The anastomosis happened before because it has to travel in the distal ileum, in the colon, and then get expelled. But the interesting thing about diabetes is we know when the anastomosis happen when their sugar drops. If they have a continuous monitoring of sugar, there is immediately when the anastomosis happen, a drop of sugar. So that's pretty cool and interesting. Some patients don't see their magnet passed. You have to have an X-ray done from second week, and then every week to prove that the magnets have passed. And this is, even though we did this only for type 2 diabetes, there was a 54% excess weight loss at 1 year. And you can see the hemoglobin A1C drop in these patients, and half of the patients were cured from their type 2 diabetes or resolution with just the positioning of 2 magnets. The results are early because we need to follow them for another year because they are still in effect by year 2 of this. And this is a 4-centimeter magnet, and we're repeating the study with the 5-centimeter magnet, which gives even more results. So I'll stop here just to give you a little bit of what's coming.
That was an awesome demonstration. I mean, mind blown away. So I would like to start off with the first question. So Dr. Gagner, can you share some insights on the historical evolution of magnetic anastomosis? Like, where did this originate? What were the major milestones, and how did we decide to use this for bariatric surgery?
Yeah. So compression anastomosis is not something new. As you know, it was used was very popular at the beginning of the 20th century, end of the 19th century. Surgeons had devised a metallic button to put in between 2 bowel loops to make an anastomosis. Dr. Murphy in Chicago was quite popular, had invented the Murphy button, and in fact, the Mayo brothers used it at the Mayo Clinic for several decades. And in France, Dr. Jaboulet in Lyon has invented also another button, very similar. This one was screwing, the other one, Murphy, was with a spring load and a click. And they used it for gallbladder to bowel, small bowel to small bowel, colon to colon, small bowel to colon, stomach to small bowel. And it was quite popular. Then sutures took over, and it restarted again with the absorbable material. A company called Davis and Geck invented the polyglycolic acid, and this is what we use for our absorbable sutures today, Vicryl-like. And the button was made absorbable. It was called a biofragmentable ring or Valtrac, and I used it in the 80s. Interestingly, Dr. Marceau, who is the inventor of duodenal switch, his duodeno-ileostomy anastomosis was always made with a Valtrac 21. 21 was 21 millimeter in circumference, and it made less than a centimeter anastomosis. using this absorbable button. It requires a lot of force, and you could only use it in open surgery. So I tried to make this laparoscopic in the early 90s, and I couldn't. It was resulting in tearing bowel. And laparoscopic stapler came in the early 90s, and that's why we've revisited this compression and anastomosis using magnets. Here in the United States, at the University of California in San Francisco, Dr. Michael Harrison, a pediatric surgeon, has looked into this and published series of experiments using animals, pigs, and primates to make these anastomoses. And indeed, he did comparison with staple anastomosis. And the magnetic anastomosis was 20% stronger when you try to burst these anastomoses. How is this possible? There's no suture, there's no staple. Well, the natural healing is stronger than if you use staples with foreign body that stays while it's healing, and sutures the same way. It doesn't heal as right. The nature is very strong, and we have the capability of healing fractures and other things pretty strongly. And so if we don't have these hindrance in the wound healing, we have stronger wound. It's amazing when you go back and look at these anastomoses, you see just a fine little white line. In animals, we do colon, we do gastric. We've done over 160 humans now worldwide with these gastric and small bowel anastomosis, and they're amazing. Just a fine line between the two. In the colon, you can't find where the anastomosis. It looks like just a regular colon loop. Very minimal inflammatory reaction. So there's been a big evolution. The Russians used it in open surgery about 4 decades ago, especially in children for bowel anastomosis. It's been used for esophageal atresia by pediatric surgeons, a magnet below, a magnet above to connect
That
a
is so
esophageal
interesting.
atresia.
So they just swallow the magnet, and then from the gastrostomy, you bring it up, and then
Yes,
it
yes, yes. They're
wow,
two small magnets, but the problem is, as the child grows, usually the
yeah,
anastomosis is not large enough and needs to be dilated or redone later. So, fortunately, we have magnets that comes now in different sizes, and our original one was 3 centimeter, and we have up to 8 centimeter for the stomach. So you can 3, 4, 5, 6, 7, and 8 centimeter magnets for different size of anastomosis, depending on what you decide. In the stomach, we use bigger magnets because the anastomosis tend to contract more than in small bowel, but it makes amazing anastomosis.
amazing. So you have done it on a stomach, like to a small bowel, where the thickness is different. And
We have, yeah,
what about,
small bowel is thinner, and a stomach is, as you know, quite thick. Now we do magnetic SASI. It's a side-to-side anastomosis between the antrum and the small bowel, and the antrum is quite thick. And we use magnets that are now 6 and 7 centimeter. We have a swallowable 6 centimeter, believe it or not, 6 centimeter magnet, and the patient, just as you see in the picture, swallows this magnet in the morning, and we do this gastroenterostomy. It's actually easier than in the duodeno-ileostomy because the gastroscope doesn't have to go very far. And maybe eventually we will eliminate endoscopy because we've had some protocol of double swallowing the magnets. So patient comes and swallow the first magnet. 2 or 3 hours later, we confirm it's in the small bowel, and then they swallow the second magnet. It goes down, and then they connect, and we can disconnect them and reconnect them at different places, and that eliminates some of the endoscopy requirements. So it's getting pretty amazing, the new protocols and what's coming. Hopefully, the surgeons will like it.
yes. So before we have quite a few questions. Just want to ask, when you do the GJ anastomosis or any sort of small bowel to this, have you seen that the marginal ulcers rates have gone down because you don't have a foreign body now?
Yeah, for small bowel, we haven't seen, much ulceration. Initially, we had the magnet of titanium staying there too long, and what we saw at when they stay 5-6 weeks, we start to see some collagen deposition, and we've seen 15% of strictures, meaning that the anastomosis is too narrow, and the endoscope cannot go through. That's what led us to invent the 4 centimeter and the 5 centimeter anastomosis. So you saw that sleeve plus magnet gave 87% excess weight loss at 1 year. So it's just like a SADI or a DS operation. But magnet after sleeve gave only 27% excess weight loss. So I was disappointed with those results, but this was a 3 centimeter small anastomosis. And we started to go by increment of 1 centimeter. But at 4 centimeter, we're at 50, 55. And then with 5, we're getting close to 70% excess weight loss post sleeve. So as a revision strategy, it's likely to be successful with larger anastomosis. With the stomach, it makes a pristine anastomosis. But as you know, a gastroenterostomy needs to be protected because you can develop ulcers in the long term. So we advocate these patients to stay on PPI.
My God, I think all of us have 10,000 questions we want to ask you. My one question was for, you said that all of the laparoscopic instruments have to be special. What about robotic? Are we able to do it at all with
Yes.
the technology we have?
Well, there are portions of the operation you can do as long as you're away from the magnet. For example, measurement of the intestine. You don't need non-magnetic instrument. They can be made with a regular instrument. There's no magnet in there. When you close mesenteric defect, your magnet is away, and you can close with the robot. You can do that. You can. I think if the robotic arm is modified and you have a kind of a magnet positioning device at the tip, you're going to be able to transport this magnet with your robotic arm. It's just that if those magnets start sticking on the side of the arm, robotic arm, then it's a problem. But we know that you can do this with the robot. You can do the docking, you can do different steps, but there are things that when it's very, very close to the magnet, you have to, it may stick and you may have to unstick it. Eventually, perhaps those who are doing robotic arms will come with metal that are not steel.
I'm curious, as you were talking about the gastrojejunostomy, one of the first things I started thinking of is different applications besides obesity as a disease, thinking of gastroparesis and doing a draining gastrojejunostomy.
Yeah.
Kind of as my brain goes down that road, I started then thinking general surgery, right? We do so many anastomoses that are high risk in our acute care surgery population, but that would potentially require an opening a little bit more quickly. Kind of next evolutions in general surgery I'm curious about.
Yeah, we have a protocol in Czech Republic to do this on palliative gastrojejunostomy for all the unresectable pancreatic cancer, duodenal cancer, some partial gastric outlet obstruction. Maybe there are some benign disease that cause this, for ulcers, post-pancreatitis, other maybe inflammatory bowel disease, etc. So you can use the magnets. If you are unable to go through the obstruction, you can make a small enterotomy and drop the magnet and close this with 1 stitch. It's a little violation of our protocol, our principle, because we tend to wanting to avoid an enterotomy. Because if you avoid the enterotomy, you avoid the risk of leaks and bleeding, and the patient can go home the same day without having, this risk. But if you have to make an enterotomy, yes, in our protocol, if there is an obstruction such that you can't pass around with the endoscope, you can do an enterotomy. So these are interesting oncologic applications. There will be also, in my view, inflammatory bowel disease of the small bowel. You'll be able to do these connections without having to go through disease bowel to make a destructuroplasty or whatever, and a partial obstruction, all kinds of things. Surgeons can invent ways to do things. You give them a tool and they'll do it.
Thank you.
We have now small magnets for biliary. This is going to be presented actually at SAGES in a couple of weeks. We use magnets in the gallbladder. You can make gallbladder, duodenum, bile duct, duodenum, bile duct, jejunum, segments of the liver and the stomach with these very cylindric, thin magnet that are passed in the percutaneously. And with an endoscope, you get this into the duodenum or the stomach, and they connect, and you make after a few weeks, you have a permanent bilio-digestive connection. We have colon magnets now. We're going to start this protocol in Europe in humans, and esophagus is another area that we'd like to treat, because on those two extremities of the GI tract, the esophagus and the rectum, is where you see the highest leak rate. And if we can treat, make these anastomoses safer without having this lot of morbidity and patients that stay long in the hospital, this would be a great save.
Great, thank you.
That's awesome. Sorry, go ahead. You can say. Do you have a follow-up question, Sheena? Okay.
I was going to pass it on to Dr. Hooper.
Yeah, while we continue with that, I just saw something on the chat. They said we could use this for SMA syndrome too, right?
Yeah, well, we've done 3 patients, and duodenal-jejunal anastomosis, pretty amazing. With a short pediatric colonoscope, usually in SMA syndrome, the obstruction is not complete, and you're able to pass beyond the SMA with an endoscope, drop the magnet in the ligaments of trites, and then just move 25 centimeter and make it transmesocolic with the third jejunum with a second magnet, and close the mesenteric defect with 1 stitch. And you achieve a duodenal jejunostomy opening without having to do a stapling, stitching, or risky procedure, because some of these patients are frail. They're usually malnourished. The body mass index is usually less than 15, and some require tube feeding for a certain period of time. So it's a great save also on these patients.
Dr. Hooper?
The implications and applications of this are really incredible. Thank you so much for sharing your time with us tonight. I kind of wanted to pick your brain about some of those long-term implications. So when we're not dividing the duodenum and making a magnetic duodenal-ileostomy, do you have any thoughts or anticipation of that weight loss, maintenance of weight loss, et cetera?
Yeah. We did the first patient in November 2021, so we have not exactly 4 years follow-up, 3.5 years, but on some of these patients, for example, in Spain, the team of Torres, who is the inventor of CD, was able to transform some of those side-to-side duodenal-ileostomy, dissecting the duodenum just distal to the side of anastomosis, and put 1 stapler, and this is transformed to a full CD. He was so excited about this. He says, it changes the whole thing. I don't have to sew or create a duodenal anastomosis anymore. And the other way is a couple of patients needed to be reversed because they didn't like the weight loss and the maintenance of high protein diet. So when you go back, you don't have any, it's a little nice funnel of duodenum to the ileum, and one shot of the stapler, it's a 10-minute operation, and you've reversed completely a duodeno-ileostomy. That's the other appealing thing for many patients, is that you don't resect anything. It's fully reversible if they don't like it.
Are there any technical
so long-term?
Oh, go ahead.
So we don't have long-term data on the anastomosis. And as I told you in the beginning, we started with a small anastomosis. So it's likely that the small anastomosis patients will require more revisions because we're learning that it requires probably a 4 to a 5 centimeter anastomosis. Now, at 5 centimeter anastomosis, we see pretty strong effects. And some of the patients, it's like being on super high dose of GLP-1. And as you know, some of the patients don't tolerate it.
Do you think there are any technical considerations in how you put those magnets or where you put them to try to get preferential emptying into that anastomosis and not through that duodenal route?
Initially, we were scared of getting close to the ampulla, not knowing, and we got too close to the pylorus, in my opinion, as a result. We know this because on the endoscopy, the anastomosis was right after the pylorus, and now we've learned to be 1 to 2 centimeter away from that, and it makes a better anastomosis. There have been some nuclear studies done in Belgium looking at the flow, because we were interested in how much flow goes through the natural pathway and how much goes into the new connection. And we were able to do this with technetium-99 nuclear scans. Although it's not perfect 100%, you were able to see that about a quarter with a small anastomosis at 3 centimeter, you were getting 20 to 25% of the flow going through the new anastomosis. So 3/4 were going through the natural pathway. The advantage of the natural pathway is that you have absorption of minerals and vitamin B and C complex. Also, you have access to the biliary tree. We've encountered patients who develop common bile duct stones, and fortunately, we're able to pass with the ERCP and get those stones out. It would have not been possible with a Roux-en-Y or a full SADI. It would have been, as you know, difficult getting to an access. So if we do a gastroenterostomy, like a SASI, magnetic SASI, you have 90%, 95% of the flow goes through the new anastomosis. And that's why these patients are really radically lose a lot of weight. Where is the exact percentage? I don't know. And it might be 50-50. It might be 60-40. I don't know. But I think 90% is probably too radical, and 20-25% we know is not enough.
Dr. Lynch, did you have any?
We'll know in the near future.
Go ahead. Dr. Lynch, do you have any questions to ask?
So one thing I've been curious about, which you kind of started to get into already, is about malabsorption after this procedure and how often you're seeing that. And I do think, and you've kind of alluded to this already, but I'll just say it, I think it's really, really fascinating, the idea that you might be able to titrate the size of your anastomosis. And it raises the question for me of, if you had a patient who was not achieving the effects that they wanted to achieve, could you go back and use a bigger anastomosis and increase the size? And then conversely, if you had a patient who maybe was losing too much weight or becoming malnourished, is there a way you could tighten that?
That's right. We've envisioned that obviously with these magnets you can enlarge an anastomosis. That brings the point that if you have a strictured anastomosis, you can correct your stricture with 2 magnets, and you'll have a large anastomosis instead of dilating every time, and it recontracts and goes back to its original size. So by using magnets, you're recreating a new anastomosis of a larger size. So you could in fact completely endoscopically go through the small anastomosis and put a longitudinal magnet behind and one in front. What we've done is we've done a second anastomosis. So there's nothing in the book that says you cannot do a second anastomosis. So when you have a loop of bowel that is along the duodenum in the stomach, what prevents you from creating multiple smaller anastomosis and tailor the weight loss? So you can do a second, you can do a third small anastomosis. It's sort of kind of a shower concept, and you can, if it's too much, you can close them with a linear stapler pretty easily, or perhaps in the future endoscopically with sewing and closing if you think that it's too much.
Dr. Ghani, I think we have many more questions, but we want to be respectful of your time. And I know you've been traveling and you have a flight to catch to Sydney. So one last question before we go. Obviously, have to ask you the last question. What is the status in America in terms of FDA approval? If I want to do this, what is one last thing, and then we'll end this.
The first generation, the 3 centimeter, got approved in July last year, but we didn't want to sell it because we thought the anastomosis was too small. So then we got the swallowable 4 centimeter. That one got approved in October of 2024, and we have a 5 centimeter that is going to be approved soon. So surgeons can choose between a 4 and 5 centimeter for small bowel anastomosis. It's approved. The problem is FASMBS, of course, does not at the moment endorse a side-to-side duodeno-ileostomy. Hopefully they will in the near future, and insurance is going to be covering those. It may require an IRB at your institution in order to be able to do this kind of experimental procedure. There's a code for side-to-side anastomosis, so some surgeons may use this, but I'm not an expert for US coding. There are surgeons like Dr. Helmut Billy in California and others. They may give you some tricks.
Perfect. Thank you. Thank you for joining us. And I think this was one of the most insightful ones we have had. Anyone else has anything else to add?
Thank you for inviting me.
Absolutely. Thanks.
Bye.
See you later. Bye.